So I've restricted myself just to peptic ulcer bleed. As you know that in the causes of upper GI bleed, basically two broad categories. One is non-variceal bleeding, which comprises about 80% or so, and this is the variceal bleed. But this changes from center to center and from hospital to hospital. For example, this is not representative of even G.V. Pant or All India Institute. These are hospitals which have active liver units, so the proportion of variceal bleed, therefore, would be much higher in that. And I've also decided to separate myself from variceal bleeding because the two diseases really are different from chalk, as different as chalk and cheese, because in portal hypertension is basically due to increased pressure. So it's a more generalized disease, whereas peptic ulcer or duodenal ulcer bleed is a very localized disease. Because of the inflammation due to the ulcer, the artery gets eroded at a single point and you have a bleed. So they're two very different, and it's not possible in 20 minutes to cover the entire thing. But what I want to emphasize about peptic ulcer disease, that this is one disease which has had a paradigm shift. Until the 80s, it was considered very much like NASH, a lifestyle disease. We were talking about type A personalities, hurry, worry, curry. Those were the etiologies that were considered. And then in around 1990 or so, the whole spectrum really changed. And this must be the only disease that I'm aware of where there is a paradigm shift, a frame shift kind of a thing, which moves on from lifestyle to infectious disease. So you could actually treat peptic ulcer with antibiotics and be cured, which was something that was completely, couldn't be even conceived about 3 decades ago. So that's the kind of paradigm shift that has occurred as we see peptic ulcer disease. And the other paradigm shift occurred with regards to the complications of duodenal ulcer. The 3 main complications are bleeding, perforation, and obstruction. And most of us now would be well aware that bleeding is in peptic ulcer, the first line treatment is always with the gastroenterologist. We have efficient modalities to treat bleeding, and there would only be a small subset of patients who would be ultimately going to the surgeons. The same is true for gastric outlet obstruction caused by peptic ulcer disease. Dilatation under fluoroscopy is now the accepted first-line management. And those patients who fail, they end up with the surgeons. So actually, we've robbed the surgeons of their bread and butter, literally, because the only thing that is left for them now is perforation. If I was to give an overview about peptic ulcer bleed, then would just summarize by saying that it accounts for about 50% of all upper GI bleeds. And as per US data, again, there's not good Indian data, it's about 100,000 admissions per year. Dr. Anand just talked about the cost of hospitalization for heart failure. That was 40 billion a year. This is much less than that, about 2 billion a year. But what hasn't changed in the last 2 decades, despite all our advancements, is the mortality rate remains about 5 to 10%, which I think was very much similar to Dr. Anand's slide who showed the mortality for CHF is also about the same range. This is one slide which I've taken from an Indian study, and this gives you the perspective that the top 3 are duodenal ulcer, gastric ulcer, portal hypertension, and erosive mucosal bleed. Now, depending on which center you are, because even if I cross the road from Pants to LNH, this would change. That being a more general hospital, we'll have much more of duodenal ulcer and erosive mucosal bleed. Unlike our hospital, where we have a big liver unit, so it's going to be a portal hypertension bias. So if you have a patient who comes with a peptic ulcer bleed, because now I'm just going to be talking about peptic ulcer bleed, there are actually 3 critical or crucial questions on how to manage this patient. So those of you who've been to Japan would be familiar with this. You find the sign everywhere in supermarkets, hospitals, airports, Deguchi, that means the exit. So the first thing that comes to mind of the ER registrar is the patient who's walking in, can he be sent out? Which means that does he require admission or can he be sent home where it can be managed? So that is the first question, because most of our centers which are active, they have a large ER load. So the registrar has to decide who stays in the hospital and who can be sent back home. So this is the first question that comes to mind. The second crucial question is, now that he's come with a bleed, what are the chances that this patient is going to have a rebleed? Because those are the patients that you want to admit, move to the ICU, emergency interventions, whereas the others who you think are stable possibly can be sent back home. And the third crucial question is, which patients would need to be seen by these men in blue or green who walk with a swagger, and ultimately sometimes you really need their help. So which are the patients who can be referred right away to the surgery, and you know that this patient would benefit by taking up straight for the surgeon? So these are the three crucial questions. So coming to the first one, which is the patient who can be sent back home? So if your Blatchford score or the Rockall score is less than 3 each, then the patient can possibly be sent home. Because if the Blatchford score is less than 3, the probability of intervention is about 1%. The probability of death is about less than 1%. Now that I've used these terms, Blatchford score and the Rockall score, just a few words, because I understand most of the audience would not be familiar with this. They are specific to gastroenterology. So I'll just give you a slide or two to show what this is all about. So the Blatchford score is on your left. That's the Rockall score. And you can see the parameters. Some of them are common to both. So pulse, BP would be common to both. Comorbid disease would be common. And the other parameters are different. So since the Rockall is more popular, it has 6 parameters as listed here. And those of you who have that Watson touch in you, you notice that it kind of fits into an acronym in A, B, C, D, and E. A is for age, B is for BP and pulse, comorbid conditions is C, D is for diagnosis, and E for endoscopic findings. The disadvantage with Rockall is that it is dependent on endoscopy, whereas the Blatchford does not require endoscopy. So this can actually be done only in centers which have endoscopy units right there, adjacent to the ER. Staying with the Rockall score, so it's scored in 0, 1, and 2, and 3. And you can see these are the various parameters. So if your age is less than 60, you get 0 points. On the other hand, if your age is more than 80, you get 2 points. If your pulse is more than 100, you get 1 point. If you have a comorbid disease like liver failure or carcinoma, then you get 3 points. If the diagnosis is benign, you get 0 or 1. And if you have active bleed, then you get 2 points. So the total score that you can get is 12. And if the score is more than 8, then the chances of rebleed are 40%, which is exactly the same figure for mortality, 40%. So the ER registrar has to decide that which patient has a high Rockall score. He's the one who's going to get admitted. So predictive scores in peptic ulcer bleed, there are 2 that we've been talking about. The Rockall score predicts the risk of recurrence, as I just mentioned, of bleed and death if the score is more than 8. Both these values are more than 40%. The Blatchford score predicts the need for intervention to control the bleeding. So the next dilemma that the ER registrar has is, does this patient require endoscopy? And second, do I need to do something before I send him for endoscopy? So let's take a look at that. The timing of endoscopy is very important. And there's been a controversy in literature. Should these patients be taken up within 24 hours or after 24 hours? And the literature is kind of sorted out now that the best results are seen within 24 hours because the need for surgery, the length of hospital stay, and the mortality stay are reduced when you scope these patients within 24 hours. And additionally, if the Blatchford score is more than 12, then these patients are better endoscoped within 6 to 12 hours. So the next question is, where do you scope these patients? So if you, in the ER, if you have an unstable patient, he should be shifted to the ICU, and the emergency endoscopy should be done in the ICU. On the other hand, if you have a stable patient, then he can be shifted to the ward, and the patient can be taken up the next morning. But there are 2 pre-endoscopic interventions that need to be done. The first is IV PPI, and you can have a real choice for the PPIs, but most of them, it's an 80 milligram bolus dose followed by an infusion at the rate of 8 milligram per hour, and this is continued for the next 3 days. What you can also do before the endoscopy is to use IV erythromycin. Unfortunately, IV erythromycin is very expensive in India, not frequently used, but those countries where it's relatively cheaper, it's an excellent agent because it downgrades the lesions and the visibility becomes much better. As I was saying, that you can have a choice of the PPIs, rabeprazole, pantoprazole, esomeprazole, and at least 3 of them have the same dosage. These need to be continued for about 3 days, and then you can switch to oral PPI. Now, the mechanism of action, how they act is when you have a bleeding from the ulcer, then that's how the clot starts forming, the role of platelets. And once the coagulation cascade is completed, then fibrinogen is get converted to fibrin. On the other hand, if your pH is low, less than 4, then pepsinogen gets activated to pepsin, and this does not allow the clot to stay there. It dissolves the clot, and that's why you have persistent bleeding. So because of the dissolution of the clot, there is no clot formation, and the patient would have persistent bleeding. On the other hand, if you use the PPIs, then the same steps are there, but since the pH is now greater than 4, then pepsinogen is not converted to pepsin, and it cannot dissolve the clot. So this part of the pathway is blocked, and the clot is stabilized. So that's the whole pathophysiology of using PPIs for downgrading the lesions. So this fibrin clot will not be dissolved, and this will stay there, allow the clot to form, and the patient's bleeding hopefully will stop. So this is a question that was answered by several trials. Do PPIs have a role in bleeding DU? Yes, they certainly do, because they decrease the risk of rebleed. They decrease the risk for surgery, and therefore they decrease the risk of death. And this is the guidelines that have been recommended by various societies. The use of IPPI, intravenous PPIs in all patients with high-risk lesions, post-endoscopic therapy, and pre-endoscopically, they may downstage the lesions. So that's the rationale for using the PPIs. The key to management of peptic ulcer bleed is actually depends on what is the severity of the lesion. And for that, we have the Forest classification that is based on the appearance of the lesions as we see them at endoscopy. This is the Forest classification, and as you can see, type 1 is the active bleed, when you can actually see a spurter coming out. It's literally throwing blood right on the screen. Type 2 is the recent bleed stigmata, which is a non-bleeding visible vessel, adherent clot, or a flat pigmented spot. And the type 3 is a lesion without bleeding, which is a clean base. Now, if you look in the right corner over there, then if you have an active spurter, the chances of rebleed are anywhere between 60 to 90%. But in type 2, that is stigmata of recent bleed, this ranges between 7 to 50% depending on what the grade is. On the other hand, if you have a lesion without bleeding, then the risk of bleeding is very low, which is less than 5%. So I'll just show you some pictures now. This, as I said, this is a spurter that you can see, and the chances of rebleed after the initial management as high as 60 to 90%. So these are the patients that you need to admit and you need to monitor very closely. This thing that you can see over here sticking out like a sore thumb, that's a visible vessel. Again, very high risk of rebleed in these patients. They need to be hospitalized. This is an adherent clot. Now, the jury is still out. What should be done? And we don't have the answers as yet. Many people think that this can be dissolved, and you take a look. Is there a visible vessel inside? Then you need to attack it accordingly, either put a clip or thermocoagulation. This is a relatively benign lesion because what it shows you is a hematine clot right in the center of the ulcer. And lastly, this is the most benign, an ulcer with a clean base. So what are the tools that endoscopists have? The oldest tool that they had was this injection sclerotherapy. Later on, this became heater probes. And they act by thermocoagulation. You just coagulate the vessel by coaptive coagulation. And more recently, we have mechanical clips which can be introduced through the endoscope. So this is the injection therapy. This is the oldest one. We inject the lesion, and when we inject the lesion, it's giving about 10 ml of normal saline mixed with adrenaline, and that causes a tamponade because you're injecting around the ulcer. So the ulcer, the artery over here that I've shown, that gets occluded. Thermal probes, they are again passed. You see, this is a 10 French tube that can be passed through the endoscope. And it is efficacious because it causes coaptive coagulation. You are injecting heat through that, and the artery gets coagulated. And again, very, very useful for controlling of bleeds. And more recently now, we have clips. These clips can be moved. You can rotate the clips, get the right position, and clip the artery right where you can see the vessel. So the next question is, what is the efficacy of endotherapy in peptic ulcer bleeds? If you're an active bleed, yes, very efficacious. If it's a visible vessel, very efficacious. But for the errant clot, as I said, the jury is still out, and we're not very sure whether you should disturb the clot and then see what is underneath, or just let it be and take it the next morning. Now, this is literally a fly in the wall look at the outline of management. So if you have active bleeding with the vessel, then what you need first is an endoscopic therapy. You continue the PPIs thereafter, and the patients need to be hospitalized for 3 days. And that's because the maximum risk of rebleed is in the first 3 days. So that's why you have to admit these patients for 3 days. If you're an adherent clot, then as I said, the jury is still out. You may consider endoscopic therapy, but they need to be given the IV PPI, and you need to hospitalize them again for 3 days. For the flat pigmented stalk or the clean base, the hospitalization is at best for 1 to 2 days, and they can be managed much more easy. This slide shows you what the Lakshman Rekha is. Now, what it tells you is you should know your limitations. And this is Indian mythology about the Lakshman Rekha. What it tells you that the gastroenterologist is not supreme. He should know his limitations. And there's a red line there, and you shouldn't be crossing that. So the management of non-variceal bleeding is based first on pharmacotherapy with IV PPI. The next step is endoscopic management, and there is a small subset of patients who do not respond to both, and they have to be referred to surgery. There is no point persisting with medical management when the patient can be saved by surgery. So that's the concept of the Lakshman Rekha. You recognize that this medical therapy is a failure in these patients, send the patient for surgery. Surgery has a definite management for severe life-threatening hemorrhage, not responsive to resuscitation by medical means, and failure of medical therapies. So this is the small subset of patients which ultimately have to be taken for surgery. And since this talk was all about decisions, I'll end by saying, if you make the right decision, it doubles your confidence. But if you make the wrong decision, it doubles your experience. As far as endoscopy for peptic ulcer is concerned, I'd rather err on making the side of the patient by sending him for surgery rather than persisting on medical management. Thank you very much for your patient listening.
Thank you, Dr. Puri. We may have 1 or 2 questions if anyone wants to. Yes, sir, please.
Very rightly said that PPI are to be used in the very initial stages. For how long you would like to use PPI, even after 4 weeks if you want, and what are the long side effects of PPI in those conditions? Because we Indians are in the habit of taking PPI from the years together.
Maybe I should start by taking your last question first. The thing about PPI is that they're generally considered to be very safe. They have been taken for a decade without anything. And there are very limited data to suggest that they may be interfering with iron metabolism, high risk for CDI, and very minor complications. So in general, they are safe drugs. But coming specifically to your question, how long they should be taken? Well, beyond 3 months, if there is an indication, for example, if the patient has to be on anticoagulants or on NSAIDs, then those are the patients you might need to give indefinitely. So cardiac patients who are on antiplatelet drugs, you might need to continue this indefinitely till as long as they're taking their antiplatelet or anticoagulant drugs.
You have a lot of side effects now coming up as PPI. One is bone metabolism.
Yes.
That's very important. And now even from A to Z, all the doctors are being using from all the specialties. Now, don't you think so that is our pertinent duty to switch over to something like pulse therapy even, or even maybe alternate day, or whenever it is to be required?
Well, all the three things that you mentioned, they are all options that need to be taken, especially in the elderly. But for the younger people, less than 60 years, this is not so much a problem. We hardly see, I mean, you really have to do a study to find out minor differences in these patients with reference to bone metabolism, etc. But in general, they are one of the safest drugs in the market. They have no severe adverse side effects at all. So the need that the patient needs to be given a PPI, for example, those patients who patients with rheumatological problems or patients with heart disease who need to be given specifically NSAIDs or antiplatelet drugs, then they can be given cephalosporin, and you can monitor their adverse events periodically.
Or we are making them addict.
No, there is no question of addiction. I mean, but the point is well taken. If the patient doesn't need a PPI, he shouldn't be given a PPI. That's as simple as that.
Surgery. And patient is having the liver cirrhosis as well.
Well, liver surgery for what? I wonder. The number of patients who are now referred for surgery for portal hypertension bleed is really minuscule, you see, because surgery, the morbidity associated with a child, mostly the patients who bleed, their child C or B and C. So the morbidity and the mortality of the surgery, major surgery in these patients is so high that that really wouldn't be a recommendation. Yes, in patients who have EHPVO, that is extrahepatic portal venous obstruction, and they have repeated bleeds or they're not controlled, and they are the ones who can be taken up either for devascularization or other shunt surgery because their liver function is good. But I wouldn't recommend surgery at all. I mean, surgery probably is not considered with the arrival of things like TIPS and BRTO. Then you really don't need to go for surgery at all, sir. It's kind of obsolete, I would say.
Thank you, Dr. Puri. Any other questions or comments? Sure, sir.
I have been, yesterday in Calcutta, so one of the gastroenterologists, he mentioned that you shown one slide that pH 4 and then it should go up immediately when the bleeding starts, because that's very important aspect. So he was speaking about that speed of PPI action is very, very important. And there was one slide shown that rabeprazole works in 12 minutes, pantoprazole works in 354 minutes, and then omeprazole, I think omeprazole, I think he showed, I don't remember. So what is your opinion about it? Because he was mentioning that the fastest action is important when you are going to control the GI bleed or PPI, speed of action.
So what you're asking me is if there is a first among equals. See, all PPIs, all the guidelines mention that you need to be given IV PPI. But yes, if there is a faster, because esomeprazole is the fastest acting, so that can be considered as first among equals. But otherwise, the results, the data that we have, they show that no matter which PPI that you use, after all, you've given an IV PPI, and once the patient comes in, so you have that window period in which
he was speaking about IV only.
I'm talking about IV itself.
Okay, so you recommend that whichever is working faster that need to be recommended.
So the guidelines say that all PPIs are equal, but if you were to twist my arm, then I can say yes, you can use.
That's what's on the purpose, because I saw the slides yesterday. Yeah? Anyway, thank you very much.